All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So the discussion today is about the study that is in these scientific reports in Nature. The study is from Israel, and there has been a lot of circulation of this article, and rightfully so. There are some very good points in here. And then there are, of course, criticisms as well and attacks on this study as well. So today, what I'm going to do is I'm going to look at both the aspects of this study. What are the authors saying? And then the criticisms, and then if those criticisms are valid or not. So these are the two basic topics here. We might actually need more than 10-15 minutes. So hang in with me and let's look at it. So this is drbeen.com. If you needed some more access to the premium account, you can go to drbeen.com, and for a very, very inexpensive price, you can get access to 1,000 videos. Okay, so this is the study. Increased emergency cardiovascular events among under 40 population in Israel during vaccine rollout and third COVID-19 wave. This is scientific reports in Nature. And about the scientific reports is an open access journal publishing original research from across all areas. And you would see in a few minutes that this would become relevant. That's why I'm presenting this to you. Global Influence Scientific Reports is the sixth most cited journal in the world, with more than 540,000 citations in 2020, and receives widespread attention in policy documents and the media. And similarly here, expert peer review. Scientific Reports is led by the same ethical and editorial policy guidelines as other nature resource journals to ensure that all the research we publish is scientifically robust, original, and of the highest quality. Then these are some figures that we will look at while we are looking at the study. This is an other study that I discussed a few days ago. This study is published in the Journal of Pediatrics, and this was from the US. And this study said that in children who had myocarditis or pericarditis, or the cardiac damage after a vaccine, from 3 to 8 months later, those children's heart's functions had become normal, but the damage or the fibrosis was still showing in all cases from 3 to 8 months. And the author said that we will do a follow-up after a year as well and come back and provide their observations. The point here is that when the myocarditis occurs, whatever is the reason, that may be COVID or the vaccine or something else, there can be remnant damage to the heart or the signs of recovery in terms of fibrosis and scarring that might now live with the patient for a long time. This is another study. This is about the SARS-CoV-2 vaccination and myocarditis or myopericarditis population-based cohort study. And this is from Denmark. And it says over here, vaccination with mRNA, 1273, that's Moderna, was associated with a significantly increased risk of myocarditis or myopericarditis in the Danish population. Myocarditis means the inflammation of the heart muscle. Myo is muscle. And myopericarditis means inflammation of the heart muscle and the layer around the heart, primarily driven by an increased risk among individuals aged 12 to 39 years. The study from Israel is about Pfizer. While BNT162b2 vaccination was only associated with a significantly increased risk among women. An Israeli study also observed that the cardiovascular events were more common among women after Pfizer. This study says a similar thing. And then here is some criticism that I'm going to go over after I present you the study so that we can look at it together. I think that this criticism itself can help, can be helped a little. Okay, so let's start. This is the medical disclaimer. This is not a medical advice, just informational. I have no disclosures. We are still living in the BA1, BA2, XE timeframe. or era. This is the little nerdy cartoon I drew yesterday. So here we have a naive T cell who has gone to therapist, and he's saying, I had a nightmare that I am in thymus for training and I am self-reactive. So tell me, what does it speak to you? All right, this is the study. So this study was deemed exempt from review by the Massachusetts Institute of Technology Institutional Review Board. The study was also approved by the research committee of the IEMS, that is the Israel's emergency management system. So it's an approved and decent study. The summary is this: what they did was they looked at the data for cardiovascular events, especially two events: the acute coronary syndrome, or ACS. Acute coronary syndrome is any sudden reduction in blood flow to heart, and that can become a heart attack. That can be a heart attack. And most common symptom is chest pain. Then there are other things as well, like shortness of breath and fever and the radiating pain. But most common is chest pain. So that is acute coronary syndrome. Coronary are the blood vessels of the heart, and they can become constricted, they can become blocked, and so on. Then the other disease or cardiac outcome that they saw, or they calculated or counted the calls for, was sudden cardiac arrest. Or cardiac arrest is usually sudden. Cardiac arrest is a temporary or permanent sudden stoppage of heart. So either sudden reduction in blood flow to heart or sudden stoppage of the heart. These were the two events for which they were looking at the calls. And I liked their data, or their this new insight, that what they did was, instead of self-reported events like we have VAERS, they actually went to the database for the emergency services and looked at that data. I think we should also do these kind of things over here. So there's something good about this study. The study's time period, what they did was they divided the cohorts into three groups. They looked at these cardiac events in this population, 16 to 39, before pandemic. So that was their cohort 1. That was 40 months of normal period. This was from January 2019 till February 2020. Remember, 2019 December is when the COVID started, and by February it had started, or March it started reaching other countries. So they took the time from January 2019 till the February 2020 as a normal time, and they calculated these cardiac events during this time and saying this was a normal time. Then from March 2020 till December 2020, they took that as pandemic period where the vaccines were not yet in the play. Then they took 2021 January till June 2021, and they took that as COVID time, wave 3, plus vaccination time. And they compared these events in this age group in these periods. That is what they did. And what did they find? They found, I'm quoting from the study, the main finding of the study concerns with increase of over 25% in both the number of cardiac arrest calls and acute coronary syndrome calls of people in the 16 to 39 years of age group during COVID-19 vaccination rollout in Israel, January to May 2021, compared with the same period of time in prior years, 2019 and 2020. So when they compared it to the normal time, they saw that there was an increase in the calls. That's it. That's what they saw. And you would see in the criticism that people said, actually, let me just read it just for the context. So if you see here, there is a criticism here where they said that what they found was there was a significant increase in these events for young people right around the time when Israel was vaccinating its population, but no overall association with COVID 19 infection rates. They suggest the vaccine may be the cause. Now, if we go to the paper itself, you would actually see they do not suggest anywhere that it is a cause. They're actually saying, while not establishing causal relationship, they say that right in the abstract. The finding raise concerns regarding vaccine induced undetected severe cardiovascular side effects and underscore the already established causal relationship between vaccine and myocarditis, a frequent cause of unexpected cardiac arrest in young individuals. And they actually give reference to other studies that have said this, and they said our study kind of underscores that. But if I look for the word cause, you would see that nowhere they would say, see, look, moreover, several comprehensive studies demonstrate that myocarditis is a major cause of sudden unexpected deaths in adults. So that is myocarditis. Now, can vaccine cause myocarditis? I think we all know that it can. So then look at this. Third, myocardial injury and myocarditis is prevalent among patients with COVID 19 infections. As COVID 19 vaccine rollouts often take place with the background community COVID 19 infection, it could be challenging to identify whether increased incidence of myocarditis and related cardiovascular conditions, such as cardiac arrest and acute coronary syndrome, is driven by COVID 19 infection or induced by COVID 19 vaccine. They are very clear that we don't know where is this coming from. We see the association. And even then, they're saying, hands up, it could be COVID infection itself. They're saying it. But look at the criticism. They suggest the vaccine may be the cause. And then they say, in the criticism, they go on to say that the Israeli government should immediately investigate the issue to make sure the vaccine is still safe for young people. And if you see here, they do say that the government should look at myocarditis in youngsters and investigate it to make sure that is there any harm that is happening that we are not looking at or we are not aware of, and can that be preventable? Remember, I had been doing this discussion from December of 2020, or when did it start, the vaccine? Now the time looks like a blur. Anyways, when the vaccine started, I had been discussing that this is not about saying that vaccines are good or bad. It is about saying if there is a possible harm, we should then see how to get ahead of it. Let me actually show you. They actually, in their final here, look at this. This would be critical to better understanding the risk benefits of the vaccine and to inform related public policy and prevent potentially avoidable patient harm. They didn't say that the vaccines are not safe. Actually, if you look for the word safe, there are 8 incidents of the word safe. Here you're saying 18V safe, safety, safe, right? So these are just in the references. Then this is another reference. Here, look at this. This is their abstract where they use the word safety. And they're saying Enriching current vaccine safety surveillance systems with additional data source may improve the understanding of COVID-19 vaccine safety. What's so wrong about that? They're saying, hey guys, we found a new data source that can also be used to understand how vaccines are doing. And one data source is self reporting, the other data source is emergency calls. What's so wrong? So that is the word safety there. Then look at this. They're saying this is V-safe. This is a self-reporting system. So that is the word safe in there. And that's it. They do not say anywhere that they go on to say that the Israeli government should immediately investigate the issue to make sure that the vaccine is still safe for young people. They don't say it. And then these authors here, they say that's a huge claim. No, they did not make this claim. This is just so strange. Anyway, so I'm going to go back here. Now, here is what they found. And let's look at it together to see the curiosities of these diagrams. Here is what they saw. They said, and look at this, look at the red line. The red line is the cardiac arrest calls. And when you are studying this with me, exploring this with me, we are not going to sit here and say vaccines are good or bad. We're also not going to say that this data is all perfect. We would explore it together. I think that is how we should be. So let's look at this. This is the cardiac arrest calls, the red ones. And so they're tracking these calls from before the pandemic, and then they continue in the time of pandemic. And then here, pandemic waves have started. One is in this blue area, one is in this orange area. The third wave is over here. They use before the pandemic time as the normal time. Then they use these two waves data as the COVID data. And then they use the data here where there are peaks as COVID plus vaccine data. So generally what they're saying is, they're saying, look, this is the kind of, in this age group, these are the kind of calls that used to be received. Then here started COVID, and they said, look, these are the kind of calls. So here is this gray line is the increase. There is a peak in COVID, but the calls were coming in before. So meaning they're decoupled. Then if you notice here, this gray line is COVID infection rate. And then these two lines, purple and blue, are vaccine dose 1 and 2. And what they say is that it is interesting that this red line starts increasing during the vaccination time. And they separate it from infection by saying that if you look at the gray line, the association between the red line and the gray line does not seem to be connected. And I'm going to go to the next one where they have zoomed in this part. And these are their diagrams. So here, now they have zoomed in, correct? So let's look at it once more. Here is the gray line. That is the vaccine. Sorry, not vaccine. That is a COVID infection. The red line is moving independent of that. So from this, they kind of say that it seems like infection is not doing it, or infection is not the cause of it. Then they say, but this is happening with the dose 1, dose 2, then it is specifically more with the dose 2, if you see here. And that you can see. With the dose 1, it is actually possible that dose 1 does not cause that much of an effect. We actually talked about it a couple of days ago or a few days ago, where we said that dose 1 could just sensitize a person. Dose 2 could cause allergic reactions. Even polyethylene glycol could do that, and so on. So there are possibilities that dose 2 is more prone for such things than dose 1 because of the immune system's response. So here they're saying that this blue line is dose 2. And if you see, this red line is moving up with the blue line, and then it is coming down with the blue line. So the criticism that I showed you, they had an additional part and they said, why was it not going up with the dose 1? And authors actually say that we did not see a relationship to the dose 1 as strongly as we saw with the dose 2. And they still don't say it is cause. They do not say that. They say it is an association. Then here is something curious for me, where I do not understand it well, and authors try to explain it, and I think that explanation does not work for me, and that is these two. So if you see here, this bright green is the COVID infected group 16 to 39 who was also administered 1 dose of vaccine. Remember, we discussed it that Israel had said that if you had the infection and you are beyond 90 days, then get 1 dose. This is that. However, the authors say that this uptick in these event calls is related to this bright one, the first 1 dose after the COVID infection. This I cannot figure out why. Meaning, not figure out, I cannot associate it the way they associate it here. There is a disconnect here. So to me, this does not look like a good association, as good as, let's say, they were doing it here. However, they are able to decouple. So if you see this gray line here, this gray line and the red line are kind of moving independent of each other. So this is what they are presenting. This is the only part which I'm kind of more curious about. Okay, so I'm going to continue here and we will keep looking at it. So now I'm going to just put in the reference for another study. This is the cardiac tissue changes persist 3 to 8 months after. We did this study in detail a few weeks ago. I just want to read this comment here. In a cohort of adolescents with COVID-19 mRNA vaccine-related myopericarditis, a large portion have persistent LGE abnormalities. These are the gadolinium enhancement or scanning. When you do a scan of the heart, you can still see fibrosis or edema or something in there. Whatever that is, I think it is fibrosis. But these abnormalities on the imaging are present even 3 to 8 months after the patients have recovered from the myopericarditis from the vaccine. So a large portion have persistent LGE abnormalities, raising concerns for potential longer-term effects. And this is in the Journal of Pediatrics. Despite these persistent abnormalities, all patients had rapid clinical improvement and normalization of echocardiographic measures of systolic function. So they said, we still see the abnormalities, but function had improved or become normal. And I had made this comment then as well, that heart doesn't need to, if it has some injury somewhere, it doesn't need to just become failed and go away. It will continue to do its function. It's one of the most resilient part of our body. We take rest and we stop. The heart's rest is relaxation and then beating again. Otherwise, it has to work for our whole life. And so it tries to work with the workload given. But that buffer of the heart may have been reduced. So we don't know. And these authors said we'll come back after a year and provide more data on it. So I wanted to connect this here to say, if vaccine-related myopericarditis is occurring, it is possible that in children, there is some persistent issue that would be there. Now, what is the percentage of that? How long would that occur? I do not know. And the data still is coming in, like this study from Israel. Now, going back to the Israel study. So what did they then find in the data? They said a statistically significant increase of 25.7% in cardiac arrests. Cardiac arrest is, and these are calls, cardiac arrest is sudden stoppage or cessation of heart function. And p-value is lesser than 0.05. That means it is significant data. So 25.7% increase. A statistically significant increase of 26% in acute coronary syndrome, ACS. And that is also statistically significant. Again, those folks who are saying this is all a fluke, this is just a coincidence, these are still independent. Somebody made this comment that, well, if you torture the data would say what you want. There is a very important point in the study. And that point is, there is another way to enrich. If I borrow author's own statement, right in the abstract, they said, enriching current vaccine safety surveillance systems with additional data sources may improve the understanding of COVID-19 vaccine safety. What's so wrong about that? Back here. Now, then they say, for individuals of age 16 to 39, while vaccine-induced myocarditis was predominantly reported in males, it is interesting to note that the relative increase of CA and ACS events was larger in females. And I just showed you the Denmark study as well, where they said with Moderna, that was a propensity towards males. And with the Pfizer, they saw that the propensity was more towards women. So let me show you that once again. Here, if you see here, they're saying primarily driven by an increased risk among individuals aged 12 to 39 years, while BioNTech, so this was Moderna mRNA, while BioNTech 162b2, that is Pfizer BioNTech vaccination, was only associated with a significantly increased risk among women. So there is something in there that is more towards women. And I saw people criticizing this as well. This may suggest the potential underdiagnosis or under self-reporting of myocarditis in females or other unique patterns, which is consistent with ongoing challenge of gender-related differences related to cardiovascular disease diagnosis and care. So folks are making fun of this statement as well, to say they're just now making strange connections. I think that they're providing data to say, look more into it. Now, the data that they had was from IEMS, that is Israel's emergency call system or 911 type system. It is 101. And then they also had the data for vaccination from the Israel's government data. Now, population level stats, what was the overall cohort? So what they did was, there were 3.5 million total population in this age group, 16 to 39. Remember, Israel is about 9.5 million, I believe, and 3.5 million are 16 to 39. Out of 16 to 39 group, this 3.5 million, there were 30,262 total calls during this study period for cardiac arrest in this group. Out of these 30,262, 945 were the vaccine associated or during that time. And that is 3.1%. Similarly, acute coronary syndrome calls were total out of this 3.5 million people, 60,398 during this study period, and 3,945 or 6.5% were in this cohort who were vaccinated as well. Now, among 5 million, so how many were vaccinated? Then that would become the next question. So among the 5.5 million, and they call them patients. I do not know why did they call them patient. They are vaccinated. Was that they had COVID and then they had this, or this seems to be an incorrect terminology used here. They said among the 5.5 million patients receiving their first vaccination dose, I think it is people, and 5.15 million patients receiving their second vaccination dose, 2.38 million or 43.3%, and 2.17 million or 32.2% were of age 16 to 39. So during this time period, 5.5 million people got vaccinated, out of which, if you talk about two doses, 2.17 million or the 32.2% were youngsters. So that is a population cohort. Then what do they say in limitations? They have many things discussed, but look at this one. Hold on to this one in your mind. They're saying it is important to note the main limitation of this study, which is that it relies on aggregated data that do not include specific information regarding the affected patients, including hospital outcomes, underlying comorbidities, as well as vaccination and COVID-19 positive status. Such related data are critical to determine the exact nature of the observed increase in CA and ACS calls in young people and what the underlying causal factors are. So tell me, did you hear in all of this that they said, here is the cause and the vaccines are not safe? I'm not trying to bash the study or to defend the study. I just want us to look at it from the way authors present it and then make our opinion. For example, one part of the graph did not make sense to me. So these are the limitations they talk about. So here are some criticism from the same thread I showed you. They said they suggest the vaccine may be the cause. So I showed it to you. They said, while not establishing causal relationship. Then they say, third, myocardial injury and myocarditis is prevalent. I read that before as well. They said, we actually do not know exactly. Is it the infection? Is it the vaccine? I would say infection plus vaccine. Or is it something else? So moreover, such increases may even be caused by other underlying causal mechanisms indirectly related to COVID-19. For example, patients delaying seeking emergent care because of fear of pandemic and lockdowns. I think that the authors did a good job of presenting areas where they did not have the causation relationship. And they were clear about it again and again. So saying that they suggest it is the cause is wrong. Then look at this. The paper suggests, this is also from their paper, several important policy implications. So now this is also criticized that why did they say that government should work on this? Check it out what they're saying. What they're saying is the following. Tell me if it doesn't make sense to you. Doesn't matter you are pro-vaccine or you are not pro-vaccine. Tell me if it makes sense to you. What they're saying is, first, it is important that surveillance programs of potential vaccine side effects and COVID-19 infection outcome incorporate EMS and other health data to identify public health trends and promptly investigate potential underlying causes. They're saying it is important that you use more than just self-reported systems. Add EMS to it as well. I think we should do that here in the US as well. And then they're saying that if you see something like this, a strange correlation of doses with this, then promptly see what it is. Yes, why not? What's so bad about that? Then they say specifically prompt so they said prompt, which is fine. That's a good term. Prompt investigation is needed to better understand the potential underlying causes of the observed increase in cardiac related EMS calls. They said, please promptly figure out what is causing this. If they were saying that the vaccine is causing this, wouldn't they simply say that we think this is the vaccine doing it? Please go and stop the vaccines and we'll talk about it later and investigate in the meantime. They didn't say that. They said this is increased. It is important for the government. Who else is going to do it? It's important for the government to do some investigation on it. I think it is a fair thing. Even if we said this is not COVID related, this is not vaccine related, this is just some third thing, I'm going to make up something. Let's say this is the stress of the pandemic. Still, it's worth investigating. That's what they said here. So, in cardiac related EMS calls, including vaccine and COVID 19 infection related factors, and COVID 19 related factors, as well as additional factors, such as willingness to seek hospital or EMS care, reduced access to care, increased public awareness to post-vaccination adverse events. Second, it is essential to raise awareness among clinical folks, and that's what they said. It is also interesting to use these kind of data to say, hey, there may be a problem. Be aware. What's so bad about that? Do you see in here anywhere that they are saying there is a cause, they're saying there is no safety, and they're saying that immediately just go on a investigative path? They're saying, hey, we found something new to correlate. Somebody should look more deeply into it. We think it is vaccines time, so research more. I think they're fair to say that. Then the criticism says, or criticizing folks, they go on to say that the Israeli government should immediately investigate the issue to make sure the vaccine is still safe for young people. They did not say it anywhere. I shared it with you. The word safe is only used. Look, safe. Used 8 times. I'm going to go from top to bottom now. This is enriching current vaccine safety surveillance system. That's where one, they used it. Then, may improve the understanding of COVID-19 vaccine safety. May. Oh, sure. 2. Then, V-Safe program. 3. Then, that's it. In the article, no further word safe is used. Now we are in references. Safe, 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 safe. They never said government should just go and figure out if it is safe or not. And then the folks who are criticizing them, they say, that's a huge claim. And to be clear, it's not one that can draw from their data nor other direct studies on vaccine safety. But they didn't make this claim. Then the folks who are criticizing, they say, let's start with the obvious. Correlation isn't causation. Correct? The actual science of the paper is simply showing a correlation without controlling for much, meaning the comorbidities and other reasons. We don't even know if this increase was among the vaccinated, and cardiac event incidence varies a lot month to month. Okay. Here is what I read this before as well. They are saying main limitation of this study, which is it relies on aggregate data that do not include specific information regarding the affected patients, including hospital outcomes, underlying comorbidity, as well as vaccination and COVID-19 positive status. Such related data are critical to determine the exact nature of the observed increase in CA and ACS calls. So I can keep going for that criticism and for the study as well. So I know that this is correct, that there are some presenters who simply said, here is what we found. And then there are some folks who are just bashing this. I think they have a very important point, and that is very simply, there is an increased observation of ACS and cardiac arrests during the time of infection plus vaccine. It doesn't look like it is related to vaccine. It seems like it is correlated to, it doesn't look like it is related to infection. It seems like it is associated with the vaccine. I think, in my opinion, they could not correlate the green one with the increase. And they're saying we are not able to say there is a causality, but this is an interesting area of EMS calls, and we should look into this. That's what they did. So, this is the talk for today. Kim says, oh my God, he's so pro-vax. No. I'm not pro-vax or anti-vax. I'll tell you, I am pro-vax for myself. I think it is important for us to not dismiss that study as an anti-vax study. I don't want the pro-vaccine folks to pick up this study and to run around that this study is bad. I think they are saying there is more data to look at, and we should then look at that data to see, is it caused by vaccine? Was it something else? So it's not about pro-vax or anti-vax. It's about pro-vaccine folks attacking these folks who are presenting a study which is not an anti-vax study, but a concern that they are raising. That's what I'm discussing. So this is what we have. So Skyfrog says, let's see, 3/20/20 and 6/20/20. Let's see. So if I go here, 3/20/20. So here we are, 3/20/20. Yes. So this period, yeah, this was less. So this is 3/20/20 to 6-ish, correct? So if we go here, 3/20/19 to, let's say, 6, during this part, if you took an average, that might average out. But yeah, you're correct. There is this reduction. Maybe this is because, as the authors were saying, maybe people were not reporting the pandemic. I'm now just making a conjecture. So thank you very much. This is actually a shame if somebody listens to this and says, I am pro-vaccine, so I am doing this. This is actually protecting these authors' work from the pro-vaccine folks who are just attacking it incorrectly. Authors didn't say those things that are used to attack them. That's what bothers me. It's not about pro-vaccine or anti-vaccine. Okay, so Vinod says, is the suspicion rising from the correlation, not causation, between global vaccination timeline and emergence of variant new completely cleared off or still alive? I still am not of a belief that the vaccines themselves do it. The variants were there, but we can look at that data together as well. Okay, so how about we do this? Now we are going to go to the chit chat channel. If you have questions about this study, we can then discuss more in the chit chat channel. Let me give you the chit chat channel's name is Cool Beans Cafe Live. And I'm going to give you the link right now. Here is the link. So this is the link. We're going to go there and we'll discuss more as well. I want to close this one. So like, subscribe, and share. I think this is the only channel that actually offers to look at both sides and discuss. And then just dismissing me by saying I'm pro-vaccine, and some people dismiss me by saying I'm anti-vaccine. It's just so not right. This is how pharma is discussed. Vaccines are pharma. Here is a drug. Here are pros. Here are cons. Here is how the toxicity occurs. Here are the preventions or managements of that. That's how we should look at it. You get your vaccine or not, that is your part. That is your discussion with your doctor. They have to see what is necessary. They have to, with you, discuss comorbidities, eligibility. Should you take it? Should you not take it? I am not the one to do that. So let's go to Chit Chat and talk there. And there are some links in the description. If you would like to buy drbeen.com's 1,000 videos for a under $100 price, there is a link there. Or you can support this work as well. You can buy me a coffee, or you can use PayPal, or you can become a patron. Now we actually have Substack link in there as well. Thank you very much. See you soon.